This conference will now be recorded.
All right, guys, this is the AnCan Advanced Recurrent Prostate Cancer Call video chat for March 15. And I'm Len Sierra, I'm the moderator for today. And we will start with Roy Salziger, or his son Mark, whoever wants to speak. Roy or Mark? Are they still here?
Yeah, they look like they're talking too, but they're not muted.
So, Roy and Mark, we cannot hear you. I'll come back to you, okay? Maybe you need to log off and log back in.
Hello.
We cannot hear you. Oh, yeah,
You
who's
got
that?
us?
Mark?
Okay, I had to make some adjustments. Yeah, my dad doesn't hear very well, and so I'll be speaking for him.
Okay.
Yeah, we about I guess middle of January, my dad had a bone scan done, and it came back at his cancer. He had about 7 Mets that they were retreating, but his PSA had gone from 7.5 to 9.5. We saw his radio oncologist about 10 days ago, and we see him once a year. He's the guy that did his original radiation treatment 17 years ago. And he recommended the PSMA because of the elevated PSA. And unfortunately, we got that back a few days ago, and there are 50 Mets on the bone. And
wow. Which scan showed 7, Mark?
that was just a whatever I would call a standard PET bone scan.
Probably
Okay.
technetium.
Yeah. Wow, so there's a huge difference, huh? Even if your PSA is high, maybe it is a good idea to get a PSMA scan.
So our question was how to proceed. The oncologist, the radio oncologist mentioned PDL1 treatment and probably mispronounce it, Zofio.
Zofigo.
Yeah, to
So
RA. Yeah.
I guess the question I would ask is, are you being treated by a GU oncologist?
No, he's being treated by a regular oncologist, has been, and we were debating. My dad likes the lady, and we had been debating on calling Dr. E, and we're probably going to do that now. We're going to meet with our oncologist tomorrow and mention to her that we would like to get a second opinion, and if she would pass on the records, and we also wanted to see what you thought.
Well, I think that would be essential before making any treatment decision.
Okay, he's 90. Yeah, he's 94 years old, and
Right.
we do not want too heavy a burden on the side effects. So
Right.
we were kind of wondering. I guess she can tell us what's the best course of action.
Right. I mean, I think chemotherapy is out. There's no question to me in my mind. I don't know that I'd want to put your dad through that.
I agree with that. By the way, can anybody hear me? My image is frozen.
I can hear you.
You can? Okay.
Yeah, sounds okay. So, but again, PDL1 inhibitors are for specialized cases where you have the appropriate markers. Now, and the question is, if you've had a PSMA PET scan, and it may, rather than Xofigo, many of us might think about lutetium for your
Which is
dad.
not really available, is it?
It is in certain places to certain people, and what my understanding is that at the places where it's available, they give it to the people who could benefit most. And it seems like your dad, I mean, versus Xofigo, Xofigo is a bone targeted radioactive substance. Lutetium PSMA is targeted to the cancer cells itself. The radioactivity probably is the same.
Well, they didn't show anything in the soft tissue, just in the bone.
Yeah, so it may
Yeah.
be a question of which treatment you can realistically get.
Right.
And I don't know, Herb, I'm thinking 94-year-old versus, 60-year-old, 70-year-old. He may be put near the end of the list.
Yeah, it could be.
Don't
I
you
mean, if
don't
they
you have to have
triage it-
don't you have to have chemotherapy before they consider lutetium?
Well, that's true.
Yeah, that's true.
So has your dad ever had chemotherapy?
No, he went from Lupron. That was early on. That's back when he first got the cancer. We call Eligard has been more recent. Prolia,
Right.
Yansa, and the Yansa quit working about May of last year. We went to Xtandi. Xtandi
And
for a short time.
right. That's not unusual. I do think a course of some immunotherapy might be okay. And but I think you can't get this. I would not do PDL1 or any immunotherapy other than with a really experienced GU oncologist
Well,
who knows.
she did do some genetic testing, enough to where she said that he does not carry the marker to pass on the cancer to the children, the sons, and that what was it? The Keytruda would not be effective.
Okay. Len, what do you think?
Yeah, I mean, immunotherapy could be tough on Roy also. I think the Xofigo may be the easier route to take. You have all bone mets, so you definitely qualify. And it's readily available.
Well, the radio oncologist, which we have known for years, he said I defer to his regular doctor, but he said you should ask her about it because I think it would be easier on his system.
Mm-hmm.
Yeah, I agree with that.
But I guess my advice would be, where are you located?
Corpus Christi, Texas.
Well, I mean, I think, you could talk to Dr. E. My suspicion is she will talk to you without a personal visit.
Yeah, that would be good. Yeah, we're definitely going to follow up with that.
And I would get to her as soon as I could. If Rick can facilitate or somebody can facilitate, I think that before any other treatment is ordered, you need her opinion.
Okay.
I would like to say that I'm not sick, I'm in no pain, and I feel good, and I exercise every day.
He's also sharp as a tack.
No, Roy, I think that's why I think there will be treatment options open to you because you are in such great shape.
Okay, we'll check and see.
We'll work on it from our end.
But I think for us to make any recommendations now without hearing from a geo-oncologist first would be premature.
Yeah, totally agree.
Unfortunate that we had to get on this AnCan before we had ever even heard of it.
Well, it is unfortunate. But you're here now, and I think we can move. I think there's a good way. There will be a way to move forward, and I'm sure Lenny will know it. I really have confidence in that lady.
Absolutely, I agree. How long a trip is it from Corpus Christi to Houston?
It's about 3.5 hours.
Oh, that's quite a trip. Yeah, so tell Dr. E that, and maybe that'll grease the wheels a bit to get a telehealth visit.
Well, we will. We'll see what we can do.
She does do telehealth, and she will do a Zoom call with you either at the very beginning or the end of her day, typically. So you might have to get up early.
We can do that.
All right. So do you have the appointment scheduled yet?
No, we're going to wait since we are going to see our oncologist tomorrow. We just wanted to let her know that we're going to talk to the doctor in Houston, and just thought that would, since we don't have to wait long, we'd just be polite.
Yeah, I guess you can ask her if she's willing to coordinate care with Dr. Eleni. Okay.
We thank you.
Sure. Anybody would like to comment on Roy's case?
That sounds like a good plan, actually.
Yeah, Dr. E is very open to virtual visits.
Are you on any drugs now?
He's on the Xtandi.
He is. Has he ever been on Zytiga or Abby?
Yeah, he was.
They didn't want him to take the Zytiga because he has stage 3 kidney disorder.
Oh, yeah.
But he was on, but wait a minute.
He's on Janssen.
He's on Janssen, which is abiraterone.
Yeah, she said that the Janssen would probably be easier on his kidney. I have no idea.
Yeah,
You're gonna have to make sure Dr. E has access to all his records. If he's got some other things going on, she needs to know about that before she can weigh in. So I don't know how you transfer your records, but she's got to have access to it.
Well, we'll see what we can do.
Yeah, does your current provider have a patient portal?
I don't know. It's with TRICARE for Life.
So I guess, who would know TRICARE? Jim? Do they have a patient portal?
Right.
Can you access your medical records online?
TRICARE for Life really isn't a patient kind of portal. All that you do happens to be to find a provider, and they pay for it.
I see. So TRICARE is like insurance.
Yes.
Yes.
Hey,
So,
there was something else about the, about the Xtandi. I believe the PSA is still continuing to rise. Okay, isn't that true, Mark?
Yes, it's been going up for the last year. With the onset, it went up to 7.5 in the middle of the summer last year. He started the Xtandi, it went down 2 points, and then it steadily went up to where it is now at 9.5 or 10.
Okay, so it,
I mean, can I ask a question? Do you remember when he was originally diagnosed, what his Gleason score was?
3 plus 4.
Okay, so it was sort of this. I think what you're saying is consistent. This is a very slow growing, least aggressive type of tumor that you can have, which is which really, has given him all these extended years, and it ain't moving very fast now either.
What I was surprised at, and I know you guys aren't doctors, but I don't understand why one scan showed it in retreat, and then the PSMA showed so many more, and his radio oncologist said that those were active.
Mm.
Yeah, it's just that the PSMA scan is much more sensitive.
Exactly.
So the 7 mets that were picked up with the traditional bone scan, you can throw that result out the window. That's kind of meaningless.
Well,
And I'm not so sure. Go ahead, Herb.
But Len, I would argue that it doesn't change that the Pylarify scan does not change the treatment plan.
No, I'm not saying it changes the treatment plan, but it does show that his cancer is on the march. I mean, just because his PSA hasn't risen much, radiographically, he's progressing quite a lot.
Right. So do you have any questions? Roy or Mark, do you have any other questions for us?
No, not at this time. We just need to get more info.
Yeah, make that appointment with Dr. Elaney ASAP.
I put her basic contact information in the chat.
Yeah, I've got it.
All right.
Good
guys.
job. Good job taking care of your dad, Mark.
Thank you. He's a good man.
And we move on, guys.
He's a very good man.
All
right.
You got to hold it still, Julian. Hard to read when you're moving it around.
I think
it's from today.
Mark, how often do you get your PSA checked?
Been getting it once a year.
Good.
And so far, so good. Also, one other question I had for you guys, maybe you've heard about it, maybe not. I saw just by chance online, and I saw just recently, a few days ago, that there was a Chinese study on melatonin that I've been taking it for 30 years to sleep, and they said it has an effect on slowing down or maybe even checking prostate cancer. Have you heard that?
Not really.
I've heard it, but I don't know that there's a lot of. I think the evidence is a little on the weak side.
Yeah,
but I have heard of it.
Mm-hmm.
Okay, we're done.
Okay, thank you.
Thank you.
Come back next week and let us know what's going on. And I'd like to go to Dennis Correa. You said you have an update for us, Dennis?
Yeah, just very quickly, I got my latest blood work results, and PSA is continuing downward, even on that reduced abiraterone dosage. So it seems to be working pretty good for me. And I'm going to keep that route going until PSA starts to rise again, I guess.
Good news, Dennis. So are you just taking Abby or are you taking Lupron as well?
No, I'm back on the Lupron also.
Okay. And how are you feeling physically? Is it
I
fatiguing you?
feel better. I don't feel as many of the side effects that I think was probably due to the Abby. So I don't, the hot flashes are very minor when I get them. I don't get as many of them. Not as much fatigue. I'm exercising more. Changed my diet a little bit, kind of more towards the vegetarian side, not complete, but working at it slowly. Other than the fact that I had a little muscle issue in my neck that took me out of golf for a while. This is almost like 2 months ago now. But they found out I didn't have any cartilage left in my neck. And they had a diagnosis for it. I don't remember the name of it. But so they said, we're not ready for surgery yet. You're going to do the physical therapy. So they put me in physical therapy for 6 weeks. Coming to the end here Friday, and feeling a whole lot better. So no more pains and headaches and stuff like that. So that's kind of motivating to keep going with the prostate stuff.
That's great, Dennis. So how long was your drug holiday before you went back on?
Almost a year, Len, but we, let's see, it started coming back. PSA was coming back after 12, 6 months, 7 months. It went up from that was the first beginning to show it was rising. It went up from non-detect to 0.1. And then that was in January last year. And then by April, it was up to 0.9. May, it was up to 1.7. And that's when we talked about getting the PSMA scan. And that changed the path of things a little bit. And went up from the 2.8, went up to 3.4. By the end of July, it was 4.6. And then we got the plan to do the radiation to the sacrum and the prostate. Had that done. And right after that was done, and we checked the PSA, we knew it was going to be up, and it was up to 11. That was mostly, I think, because of the radiation to the prostate. So that's gone down significantly. Like I said, it's down right now to 0.2. So all that stuff in combination has been working. You know, every time you get your blood work, you get a little hyper about what's it going to be, where's it going to go, and but no matter how much you try to convince yourself not to try to think about it, you get to that last week or so before you're going to get your blood draw, and you start thinking about it. So,
hey Dennis, this is John. I was going to ask, how long were you on treatment before you stopped?
That was about 5 years.
Oh,
yeah,
a long time.
2016, I was diagnosed with metastatic advanced large volume disease, bone mets, and numerous lymph nodes. And so that's when I right away tried to find the best doc I could in the area. And the recommendation was the chemo with docetaxel. And we did that with the Lupron at the same time. That gave me about a year before it started to go up again. PSA was rising. And we got the Abby. And over time, that brought it down pretty quick. And we stayed down at non-detect. And then, discussions about, taking a drug holiday so I could see if I get any testosterone back or reduce my symptoms, obviously, from the drugs. And thought about it a little bit and decided to do that.
So you were non-detectable for what, a couple of years?
About 3.
About 3 years, and then they thought it was worth trying off.
Yeah,
Okay, thanks.
because I didn't have a prostatectomy, so it wasn't one of those that, you know, I still have my prostate. So. Gleason 9, 5 + 4.
That's great, Dennis.
Yeah,
that is so great news.
Yeah,
It's inspirational.
it is. It is. I just wanted to share with everybody. There's always hope out there, no matter what you think, where you're headed, and right, especially during this time, we are making researchers and docs are making a lot of progress on our disease from all aspects of detection, you know, early treatment, metastatic stage 4 disease. So that's the whole hope, is that you can stay around long enough till maybe there is a cure. Or maybe they do find a way to actually prevent morphing to neuroendocrine disease. There's a lot of research going on that too.
Dennis, while you were on drug holiday, how high did your T levels get?
Not very high. What was it, 30 some, I think. It never did rise up to 100 or anything like that.
Was it enough time to feel better though?
Yeah, right. Whether it's the actual T level or just being off of the drugs themselves, their side effects, you know, you do feel better.
All right, any questions for Dennis? Thank you, Dennis. In that case, we'll go to Jeff Markey.
Hello there. Well, I had some surprising results from my last 2 PSA tests. I started Abby a year in January of 21, and 2 weeks after starting it, I had a 1.2 PSA. 2 weeks after starting it, it went down to 0.8, and then it never saw anything below 1, at least 1 again, until last month. And I mean, 5 months ago, I was at 2.2, then it dropped to 1.6, then it dropped to 1.5, then it dropped to 1.1, and a month ago, it dropped to 0.4. And Harstark said to me, maybe it's a lab error. She wasn't sure. And the next month, this month, a week ago, it dropped to 0.3. I haven't been that low for 2 years. Abby has just been up and down, but I changed a few things. A couple of months ago, instead of doing 2 times around the track down the block, I started doing 3. So I increased my walking, and I do that twice a day. So I increased my walking from about a little over 2 miles to almost 3. And I also cut back on a lot of meat. I'm eating chicken, I'm eating fish, but I don't eat other meats very often. And I don't know if, I also stopped eating pistachios because they weren't on the list of preferred nuts. And I mean, it's hard to believe I'm down to 0.3 now, but Abby seems to be working. So it took a year and 2 months to get here, but at least I may have a few more months of being able to stay on Abby.
That's pretty amazing. That the only things you really changed were your exercise and you cut out meats. So that's it's quite a testament there. Who knows?
Yeah,
maybe that's. I mean, Abby, you haven't changed the dose of Abby, right? That's been the same.
No, nothing else. And I had to start Pradaxa a couple of days ago. And I still can't get my blood pressure right, something I'd never had a problem with before Abby. But at least I'm working with a cardiologist now, so should be able to get things straightened out. It's Abby sure throws you for a loop. And they told me, I did a test, a cardiogram. That they said, they came up saying I had an aneurysm at the end of the study, at the end of the test. the report came back saying I had an aneurysm, aortic aneurysm. And then a friend of ours said, wait a minute, you're 6'4", you weigh almost 190. You're like, instead of 4, you're 4.1. That's normal. And then the cardiologist that I'm working with said, you don't have an aneurysm. It's just, you're so big that your dimensions are larger. And immediately canceled the test I was supposed to take. But crazy things happen. But, it's just, I had an AFib event in December, and I'm finally do something about it because Abby is not my friend. At least my heart's friend. That's about it, folks.
It's your prostate friend, but not your heart friend.
Right.
Yeah.
Good
Okay,
news
any
stuff.
questions for Jeff?
I agree with you, Jeff. It's a tough one on you. My blood pressure just shot up when I started. I had to change heart doctors because my original guy didn't catch it.
Oh.
Well, for me, Peter, I caught it, and then we had to raise my blood pressure medication twice. But what I found more interesting was that now that I'm off of Abby, it's not dropping.
Oh boy. Yeah, this morning I took, sorry. This morning I took mine, it was 140, which is, and they've doubled my losartan. It's.
So what's your dose of losartan?
I'm taking twice a day, 50.
And nothing else?
Not for blood pressure. Well, the thing is, I haven't had a cardiologist, and I stopped taking my blood pressure for a while because it seemed to be getting better. But then I had to start taking it again after having this event, and it's been pretty steadily in the 130s, mid and high 130s, if not 140. So I don't know. I'll probably end up taking more. What else do people take besides a single heart medicine like losartan in order for blood pressure?
Well, for me, they added a calcium channel blocker.
Oh, interesting.
On top of an ARB, which is what you're getting. Because that way it sort of limits the side effects from either so you don't have to push the dose too high of either.
What was that called again?
I mean, there are many of them. I mean, amlodipine is sort of the paradigm.
It was a calcium, what?
Calcium channel blocker.
Calcium channel blocker.
Okay, guys. With that, anyway, I'm taking actually 2 of the calcium channel blockers. Anyway, I take the let's see, the Norvasc, okay, and the lisinopril. I also take a beta blocker, okay, to slow down the heart, and then I take the hydrochlorothiazide to bring out the water.
Right.
And so the blood pressure happens to run around probably 100 over 58 all the time now.
Wow. Oh, jeez.
I mean, that's, Jim, you think you need all that? I mean, one wonders whether that's a little low.
Well, actually, that's true, but this thing happened to start back in 1984, and they think it was caused by the Agent Orange.
Oh, wow. It doesn't cause fatigue having it that low?
Well, it does at times, but it's a lot better than having it up around, let's see, around 230 over 100 and okay.
No.
That was some scary times.
And are you on abiraterone, Jim?
Yes, I am.
Jeez, you know, when I was on Abby, it was like that. I ended up on 4 blood pressure meds, and unlike Herb, and I'm disappointed to hear that, when they pulled the abiraterone from me, my blood pressure went all the way down, and one by one, every single one of those medicines disappeared.
Well, how long did it take, out of curiosity?
For the blood pressure to return to normal?
Yeah.
Well, over a period of, it took quite a few months. It took a few months to get off all those blood pressure medicines one at a time. But about a month, less than a month after stopping abiraterone, I was starting to get blood pressures like, 100 over 60, like Jim's talking about. It wasn't, that weak, but it was fairly prompt.
Because for me, it's over a month, and it's still my blood pressure is still like in the 130 over 75 range.
My cardiologist would probably be satisfied with that.
Yeah, that's not terrible at all.
No, it's not terrible, but the point is that's with two different blood pressure medications.
Yeah.
When before I started Abby, I was on only one.
I see. I'm glad we're all paying attention to this, because I think we all know that, heart disease is the killer. That's the one that gets more guns than anything else.
Yeah, does everybody take their blood pressure? I assume we all get to take it when we go to the doc, but then it's a little high because that's classic.
Holy smokes, the white coat syndrome.
Right.
The thing, trying to drink around 64 ounces to 72 a day, let's see, and with the hydrochlorothiazide, will take that out of me. Okay, and it really helps too.
Well, Herb, I think you have to stop eating the Baconators.
Right. That's hardly on my. We do not eat salt. One of the things that we cut out early on was salt.
Good.
Good.
Remember, I work at the Heart Institute.
Hell, that's true too, but then you have to watch the potassium, okay, because provided it gets low, you will get tired. And you will get fatigued like you would not believe. Anyway, I add that.
Right.
So
I eat dried fruit, which is loaded with potassium.
Avocados, I love them.
Yeah, low potassium can kill you. It's really dangerous.
But high is even worse.
I stopped putting salt on my Spam.
And you're drinking Diet Coke with your Twinkies now too. That helps a little bit. All right, guys. Let's see. Let's hear from Jim Barnes.
Hi guys. Just to add on to the heart medicine, I'm on Entresto and Metropolo, but I was on those before I started my journey on prostate cancer here. But I have no issues. I did have really low blood pressure at times, but that didn't seem to be a concern to anyone. I had severe AFib, which ended up in me getting a pacemaker. So I've had a pacemaker in for a couple 3 years, which has been wonderful. This morning I played 6 games of pickleball and just had a ball doing it and felt great the whole way through. So, but anyway, my prostate cancer journey started 2 years ago. I was diagnosed with Gleason 9 prostate cancer, and I've been, started out on Eligard and enzalutamide. The enzalutamide had too many side effects for me. I just couldn't handle the severe brain fog that it gave me, and just a cloudy head. So I switched to abiraterone. But since then, my PSA, which was undetectable on the enzalutamide, my PSA has been rising to 0.1, 0.2, 0.3, 0.4, and now it's on to 1.1. So I'm talking to my doc about, hey, what are the next steps here? This is obviously not in the right direction. It's not a 5-alarm fire or anything. So I'm trying to, we're talking about, potential treatment methods down the road, and he wants to do a PSMA scan. I guess once my PSA gets to a certain level. But we were talking about treatment options. What are the options in the pipeline coming up? And we were talking about, chemotherapy. We're also talking about lutetium. But he said maybe the next thing we want to do, if my PSA keeps rising, is get into a clinical trial with the immunotherapies. And I just took that at face value. And I'm not knowing a lot about it, but I just thought I'd throw the question out there. What do you guys know about the immunotherapies, and are they successful? What are the side effects? Are they easy? Is it easy to tolerate? Is it better than chemo? And it almost sounded like what he wanted to do was the immunotherapy clinical trial first.
Well, I don't know, Jim. I just went through the only approved immunotherapy, which is called Provenge. Okay, and that's a therapy where you go through apheresis. They remove helper cells, expose them to an antigen, and then shove them back into you in the sense of juicing up your immune system against prostate. The data show that it's in, at least the aggregate data. Obviously, it never works for one person. You don't know for one person, but the aggregate data show that it is effective in extending life. It doesn't supposedly lower your PSA. It just extends life, which is kind of peculiar.
Sure.
But the other thing I would argue that I wonder, we've seen it with other guys in this group. I haven't done it, although I'm about to, in a way. Go through a clinical trial before you've exhausted the conventional regimens. A clinical trial means it's not shown to be effective, right? You're going to try something that isn't effective or not known to be effective in a clinical trial versus things that have been proven to be effective. So to me, it doesn't make sense to go that route first. But Len, what do you think?
Totally agree, Herb. When you've got FDA approved therapies you haven't even used yet, I would go with that before I went to a clinical trial. Immunotherapy has been miraculous for certain cancers, melanoma, non-small cell lung cancer, maybe a few others, not so much for prostate cancer. And even then, it seems to work only with patients who have either MSI high, microsatellite instability high, it's a biomarker, and or PDL1, PDL1 or PD1. So if you haven't got those biomarkers, I don't think it would be a smart move. And side effects from immunotherapy can be life-threatening. So it's, I agree with Herb, go with approved therapies first.
I mean, the immunotherapy trials with CAR T cells, with bites, both of which are the sort of the coming immunotherapy for prostate cancer, have not been all that successful, because prostate, in contrast to blood cancers or melanoma, is called what is called a cold tumor. The immune system cells that fight the tumor, which are T cells, don't like to go there for some reason. And so, we're still a long way from having an immunotherapy based on T cells, such as CAR Ts or bites, which is shown to be effective. So do you think it's a good idea to do a trial before doing conventional therapy?
Is that a question to me?
Yeah.
I mean, based on the clarity you just provided, it makes total sense to go with the conventional therapies, and the outcomes, and you have full control over what's going to happen with the administration of those drugs. So I mean, that makes perfect sense.
You don't have control. You just have a better sense that they've been effective, and also a good sense of what the side effects are going to be.
Jim, this is Peter. If I was in your shoes with a steadily rising PSA, I would jump on Provenge. I mean, you're an ideal candidate for it. You don't have much to lose. It's it doesn't have any bad side effects. Herb went through it.
I went through it. And
you'd be an ideal candidate, and also you're in a perfect spot for a PSMA scan. I wouldn't even wait for it to climb higher. If you're 1.1, you're going to get a pretty accurate reading with a PSMA scan. So you can do that too, and it's not going to affect anything. You want to do that before you do anything that might lower your PSA.
Right.
Also, this is John. I have a question. Even though it would be premature to go into non-Provenge immunotherapies, it might be a good time to get a somatic test.
I would hope it's done already. Have you had genetic testing both for yourself and the tumor?
Yes, I believe I have. I mean, there were samples, and immediately when I saw the GU oncologist, took samples and sent them away to, I forget what foundation, to determine that. And determine the type of cancer, and if there's any known research in the future that might impact that. I'm not articulating it very well.
No, but John,
that's why I'm here, to learn how to communicate better. I'm sorry, Herb, can you say that again?
No, John made a good point that for all of us, it's important to get him, before we embark on any of these kinds of immunotherapies, to make sure you have genetic testing, which shows if you have appropriate markers, it'll predict success.
Right. Okay.
So Jim, so your first move should be the PSMA scan, Provenge, and have you had lymph node mets in your pelvic region when you were diagnosed?
No.
Or you didn't?
None detected.
Okay.
CT scans and the MRIs and all that.
Yeah, so if the PSMA scan shows anything in your pelvic lymph nodes, they could use spot radiation. That might help, but we don't want to get ahead of ourselves here.
Sure. No, that's great feedback. Provenge. How do you take Provenge? What's the form factor?
You don't actually. You don't take it's. First you give it away and then you take it. It's sort of you give it and then you take it away. So what they do is you sit in your chair and they do apheresis on your blood for a few hours and take out a population of cells, and then they take out your what's called dendritic cells, and they send those off to the factory where they get treated. And then 2 days later or 3 days later, they shove them back into you.
Okay.
So it's not a pill. You do have to go through apheresis, which for me was a piece of cake. I just sat there while they did it. And the only downside for me in the whole process was they gave me a really hefty dose of an antihistamine, Benadryl, when they put the cells back. And I was just knocked out for a few hours.
Okay.
Hey, Herb, I have a question for you. It's David Muslin. Is Provenge considered an immunotherapy?
Yes. It
And
was the
how-
first immunotherapy because it really it interacts only with your immune system cells.
Right. So how is that different possibly from the immunotherapy that Jim's doc is trying to talk him into in a clinical
Okay.
trial? Just to get that out.
Well, the newer immunotherapies are ones that are based on trying to use linkers to get T cells to attack prostate cancer. So directly take something which will link to a T cell or activate a T cell and trying to get it to attack prostate cancer cells. Whereas this takes dendritic cells, which are the cells which normally pass antigens to T cells, and treat them. And hopefully then the T cells will do their work.
Got it. Thanks for that
I
clarification.
mean, it's a little tricky to explain, David. I don't think I did a particularly great job, but one directly tries to link T cells to the tumor. The other uses this indirect method.
Provenge is a cancer vaccine.
Right. It's well, there was a cancer vaccine that didn't work, Prostvac. Right. I think the trials with Prostvac showed that it did not work. Although I do know that there are companies now that we have mRNA-based vaccines are trying to use that as a backbone for trying to induce an immune response.
Got it.
Still,
Thank
we're
you so
faced with
much.
a cold tumor, though.
Right. I mean, it's a cold tumor, and you got to figure out a way to get the T cells in there.
A lot of the Prostate
Ben.
Cancer Foundation presentations last fall had to do with trying to figure out tricky ways of getting around the microenvironment around the tumor and making it more accessible to the immune system. So it looks from that meeting like a lot of people are trying to figure out a way around that block.
I mean, John, as a scientist, I think they'll figure it out. I mean, it's just going to take more time than we have.
Well, hopefully not. But it will take time. Yeah, so I'm starting to think, Herb, we could use an immunotherapy webinar from you.
Well, we had one from Larry Fong, remember?
Yeah, we
Larry
did.
Fong talked about immunotherapy.
Yeah, but how long
and we
ago was
can,
that?
like last year.
Yeah, I guess not much has changed.
But
Okay,
of course,
guys.
Larry is into Provenge. I mean, Larry developed Provenge, so
Yeah.
that was big on his webinar.
Right. So go check out Larry Fong's webinar, immunotherapy webinar on the AnCan website.
Yeah, we'll check that out for sure. And on a final note, I've changed my diet dramatically. Somebody was talking on this on this call about the How Not to Die diet. So I've downloaded the app and I've been subscribing to that and following it pretty well. So I feel really good and really cut out all meat. I'm in South Florida. Fish is hard to cut out, but it's that diet's going well. So we'll see if it has any results. And actually, I started a regimen of turmeric as well, because they're, they talk about that having good results with cancer.
The diet wants you to cut out fish, James?
I'm sorry, John?
The diet wants you to cut out fish?
There's no, as far as I know, it does. It doesn't have any fish in anything that I've seen in terms of the diet.
Then what is this diet? What can you eat?
Are you asking specifically what?
What can you eat? What can you eat on this stuff?
It has a regimen of berries and fruits and nuts and spices and lots of beans and so on and so forth. And lots of green cruciferous vegetables, other types of vegetables. Those it loads you up with lots of veggies. That's my dinner for tonight.
Vegan, yeah?
Salmon is supposed to be good for you if you.
Plant-based diet.
It's got. Salmon has things in it that help against prostate cancer. Also, fish like trout, it's beneficial. PCF, they did a list of different seafood you could eat that was prostate friendly.
I kind of like going to the Prostate Cancer Foundation's recommendations on diet. I think they're a reliable source. Do you have the PCF handbook?
Do I have it?
Yeah.
No, I don't believe I do.
You can get it for free from PCF, Prostate Cancer Foundation. You can either download it as a PDF or you can request that they mail you a physical copy.
Mm-hmm. I'll have to check that out. This diet appealed to me. I heard it here, some guys talking about it. Certainly not, endorsed by you guys or anything like that. But some guys had some positive things to say about it. And there was an app that I could follow if I could find my phone and show it to you. But it actually, goes through and you check off boxes every time you ate a different category of food. So it was nice. It was nice to have. It was easy for me to follow and make the transition. I think the big thing is I get away from the meats and the cheeses and the Twinkies wrapped in bacon and all those good things that we talked about, right?
Yeah.
But I've been enjoying not doing meat. It's actually doesn't really appeal to me anymore, and I always used to be worried about the quality of meat that I was getting, whether it was fresh chicken or not. And now since you don't have any of that stuff in your diet, you don't have to worry about it. And I feel a lot better in my digestive system from beginning to end is awesome. The how not to die book was written by this doctor who went into all these countries where they didn't have heart disease and cancer, and he was trying to figure out why don't they have them there, and he studied the diet, and he wrote the book, the How Not to Die book. Then he came out with a cookbook, and now there's an app for it, so it's super easy for me to follow. And if that works, if I'm making that much progress with it, that's a score in my book. So I'm not gonna, mince words and salmon better or trout better or whatever. Should fish be there or not? I don't know. If there's any definitive proof there, I would be happy to check it out and follow it.
Jim, Ben Nathanson just posted the link to the Prostate Cancer Foundation handbook in the chat.
Oh, thank you, Ben. Good.
Okay,
Great
guys.
information, guys. Thank you so much.
All right, thank you, Jim. Let's now go to, let's see, Julian Morales.
Thank you, Len. Thank you
Did you
for
take my
hosting.
phone off the table?
Sir?
I was like scrambling for it so I could record.
What?
Go ahead. Go ahead,
Go ahead.
Julian.
Okay, yeah, I went to see Dr. Z this afternoon, and she made some med changes and a new regime for me. She's actually going to take me off of Zytiga Abbey, which I was taking 1,000 milligrams a day, and then it's going to taper down to dexamethasone from 1 tablet daily to half a tablet daily for 1 week daily, and then next is a half a tablet every other day for 1 week, and then stop it altogether. She does want me to exercise more, walk, and over 3 miles a day if possible, and wants me to do resistance weight training. So she emphasized exercise quite a bit. She is going to stop the 3-month Lupron treatment. I've been on it for about a year, and in about 2 months she wants to start Orgovyx, and then follow it by Nubeqa. I know that was a mouthful.
She wants to start Orgovyx and then what?
Nubeqa.
Darolutamide.
Yeah. Okay.
I know
Sounds
it's
like
a mouthful, but that's the gist of it.
all good advice. Anybody want to comment?
And my PSA is undetectable, by the way.
Terrific.
Why did the change get made if your PSA was undetectable?
She wants to get me back to normal.
But you're going to go back on hormone treatment.
Right. She wants to just monitor it and see if everything stays stable. All because of the dexamethasone and the Abbey, the heart. She had concerns about heart, because I'm on losartan, HTZ, and I was on 100/25, then I stopped it and I got water in my knees real bad, and then I went back to losartan HTZ at 112.5, but I get a little bit of water in my knees, but it doesn't stay there. It goes away because I'm walking every day. But I'll be talking to her nurse tomorrow morning, see what he thinks and what she told him in more detail.
Julian, your Orgovyx is a lower cardiovascular risk. That'll be the daily pill.
Joe, I'm not sure that's true.
I just heard a report by our friend Alicia Morgan, who is now saying it is.
There's no data which show that it is.
True, it wasn't. It was only a side observation in the trial.
Right.
I think that it has shown benefit if you have a pre-existing cardiac condition, but for those who don't, the studies don't show any benefit.
And the studies that do have been questioned on their methodology.
Yes. Right.
Yeah.
I mean, the one that really people depended on had a problem with levels of testosterone. So I'm not going to, I wouldn't say there's any difference at this point.
Well, I don't have any testosterone anymore, so I guess it's working there.
I don't either.
Well, it'll do it. It certainly is effective, but I'm not sure that there's a big difference in cardiac events.
Yeah, well, I know that they select it, but in my case, I had bypass surgery back a few years ago. So that may have been some of the element of it. But I think testosterone's dropped real quick down to 23, and the undetectable PSA shortly after a couple of months.
I think the bigger advantage of Orgovyx is your T levels will recover a lot quicker than if you're taking Lupron.
Yeah, that's what she said.
Did someone just comment? No. Okay, can we go on next to, let's see, where is he? Sorry, I'm looking for a name.
Mike Chandler.
Was it Chandler? Are you the one who wasn't here since, oh, it was John, oh, John Garvin, he just left.
No, he's still on.
Thanks, Fred. I was thinking of John Garvin, but
He's still on.
he's still on?
I'm here. I'm not. I have
Okay,
to go.
let's go to you. Go ahead, John.
I had commented. I had nothing to really update on. I'm still in control situation with the Nubeqa and the Lupron. So that's going well. I'm 0.23 for the last 6 months. My nadir, my lowest point was 0.18. So all good. Side effects manageable. But my question was, actually I put it on the chat, was the little shocking news about William Hurt this past week. Was diagnosed with terminal prostate cancer in 2018. So some of the people in the chat have backfilled me on the fact that you stage 4 with bone, and he didn't want to go traditional chemo. He went through an alternative SDF chemo. So I got my answer there.
Yeah, so, I never heard of that.
For the person who's considering Nubeqa, I haven't heard too many other people on this chat or even my other Toronto chat, our conference group that is on darolutamide. But you mentioned other stuff that you guys are taking, but they moved me from Lupron, right, and added the Nubeqa about a year ago, right after my radiation treatments. So so far so good. It seems to be doing the job, at least for now.
Yeah, John, there are at least 3 guys on darolutamide in this call right now.
Good.
Everybody's...
Yeah, the only thing we've been watching is the RBC, what do we call that when you're
anemic?
Anemic, exactly. Thank you. Yeah, so I've been running a mild anemia for better part since I started Lupron.
Right. I mean, what's your hemoglobin?
It's fluctuated. Lowest point was 100, but 107 to 111 kind of is the range.
No. Hemoglobin ranges from like 8 to 14 or 15.
Sorry. Well, I'm giving you the Canadian metric version here. So I don't know what the conversion factor is. I think it's a factor 10 or something. Probably 10. Yeah. It's a factor of 10 in milliliters, whatever they calculated on. Huh. So I would 111 would be 11.
Maybe 11.1.
Yeah. So yeah, I managed that. It's tolerable. They did a complete workup on the from a blood cancer point of view to see if there was any other factors at work in the anemia, and they came up clear on those. So it's strictly the Lupron and the ADT treatments that I'm getting that is causing it.
It's very typical.
Yeah, I understand. So that's all I had. Thank you for letting me make that update.
Well, glad you came back. Rick says you haven't been here since April of 21, so come back again a little more frequently.
No. Actually, I was there about a month ago. I only joined this group. I've been involved with the Toronto group for a better part of 2 years, but this group was about 6 months ago, I believe, when I first joined. Yeah.
Okay. I guess that's on Rick. That's what he told me.
Oh, sorry.
So he wanted me to get to you.
They got the wrong email number for me, so I don't know what maybe that is causing. So thank you.
Okay, thank you. Chandler, I don't know why I can't find the names on my sheet here.
Michael Chandler.
Michael, yes, thank you. Go ahead, Michael.
Yeah, I'm just trying to unmute. Just an update. I haven't been on the chat for a while. Just waiting for my cancer surgery. Excuse me, my prostate surgery. And thank you for directing me toward centers of excellence. And I've had great care at UC San Diego. And April 4th will be my surgery. And Dr. Christopher Kane, naval captain, veteran, is going to perform the surgery. And you all directed me to the medical oncologist, a gal, Raina McKay. Met with her and staying positive, moving forward for surgery.
Okay, that's great. We don't usually see guys who haven't had their primary therapy yet. So what was your original diagnosis? Like recent score?
Originally, the pathology department at UCSD had me at a Gleason 8, and then we sent our records off to Dr. Epstein and John Hopkins, and he downgraded. 2 of my core out of 14 core samples were intraductal, which isn't good. And thank you for directing me. I got a PSMA Polarify scan. Yeah, so my Gleason has been downgraded to a 7. And you all rock. Thank you so much.
Well, thank you, Michael, for sharing your story, and let us know how the surgery goes.
I will. And ciao.
Ciao, ciao.
Len, this is Peter.
Yeah.
Can I just, this is a good place for me to interject this thing I wanted to just mention. It's real quick.
Yeah, sure.
I don't have a, someone sent it to me, so I don't have the way to look it up online, but it's a article about a retrospective VA study about men who had surgery for prostate cancer, intermediate to high risk. And it was a retrospective study with 4,000 men, VA patients. And the analysis was that among men with intermediate and high risk prostate cancer, we found no statistically significant increased risk of adverse long-term outcomes, including castrate resistance, metastasis, and death for men who had treatment delays of up to 1 year following their diagnosis, which I found interesting because, a lot of people panic about, oh, can I wait 2 months? And the doctors often push you for, let's get on this right away. And it's even more so with guys with low risk disease. But what they're finding is that you can wait up to a year without really panicking, is without risk. In many, there's individual cases for sure, but if you're run of the mill with high risk disease or whatever, it's not going to get out of control, is what they're saying, if you delay it for a little while.
So the study was all high-risk patients?
Intermediate to high risk, right?
And I could easily believe it for intermediate, not so sure about the high risk, though. Did they stratify the high risk from the intermediate in any way?
No, it's a VA study too, so you got to be a little bit skeptical of that. I mean, it's a retrospective study. It's not. It's
Right. That's
yeah,
the issue.
yeah.
Well, you couldn't do it as a prospective study.
Right. So anyway, I just wanted to interject that because I think there's this just to counteract this idea of panic. Oh, I better get on this right away before the cat gets out of the bag or this or that. But Michael's a good instance of someone who's not delayed it, but taken their time to make sure they get the right treatment at the right time.
Yeah.
We have had people that came on and that were new that had Gleason's of 9 and had metastasis in multiple places. And I don't think that's the situation where you want to wait.
Right.
Okay.
Right. This is probably more localized disease. Although it doesn't actually say that.
Okay, Tom Schwartzel, you're up.
Wrong button. Yeah, Peter, I agree with that. When I got diagnosed, we should have waited a couple of months after we did some research and then go from there. Because what we've done in the last year was trying to back up and figure out what the status is of the cancer. So what I did last August was go off of Eligard and apalutamide in an attempt to figure out if my lungs are involved. Because I was told initially that I had metastases or lung nodules. I had lung nodules, which they considered to be metastatic at the time. And we weren't totally convinced. So I went off my meds in August, and I just had my PSMA scan last week. And as a result of that, my PSA was 2.3 at the time of the scan. As it turns out, my lungs are okay. I do have nodules, but I don't have any cancer in my lungs. So that was a relief. But on the other side, I now have 2 bone mets down in my pelvis. So met with the oncologist Monday. So I'm going back on ADT, started my Casodex yesterday. And I'll get my Eligard shot in a few weeks here. And he's scheduled me, or he's set me up with a radiation oncologist to radiate the prostate as well as the 2 mets. And that's my update. So right now we feel more in control now that we realize we shouldn't have jumped into it right away back at the start, but we feel more in control now that we know what's going on.
Tom, you originally had surgery?
No, I haven't had.
So what did you have? What was your primary therapy?
I had Eligard and apalutamide.
Oh, that's it, just hormone therapy.
Yeah, I guess since they figured I had my lungs were involved. I don't know if they thought I was a lost cause, but they just put me on hormone therapy. That
right.
They wouldn't do any radiation at the time. So now I feel better. We're going to do some radiation here and go from there.
Did the hormone therapy bring your PSA down?
Yes, it did.
How low did it go?
Oh, it was undetectable. It took about it took from December to about April to get down to undetectable. And then it took about, once I went off my medicine, it took about 6 months to get back up to 2.3. And
what was your original Gleason?
8.
The original 8? Okay.
Yeah, Gleason 8, and I was about 6.3 for my PSA. I did have a simple prostatectomy 4 years ago, where they just removed, or I guess roto-rooted it out. I was having trouble urinating, creating too much pressure in my bladder, which as a result I had a diverticuli in my bladder, so I had that removed. And at the same time, had the simple prostatectomy, which really helped out as far as going to the bathroom. So I do have one question about I know we talked about cardiologists. Now that I'm going back on ADT, is it a good idea to go ahead and find a cardiologist just to get in the door and make sure I have someone available, maybe down the road?
Always a good idea.
Okay.
Yeah, I agree.
I've just talked to a couple of cardio-oncologists in the last couple of weeks, and I think they would also agree with that.
Okay.
They told me that the way that hormone therapy affects the heart negatively is not only indirectly, like I thought, by giving us things like higher cholesterol levels, higher blood pressure, higher blood sugar, make us fatter, all that stuff. In other words, causing a sort of metabolic syndrome that it then affects the heart, but also that there are apparently some direct effects on the heart. And I asked one guy what the direct effects of the heart were. Could he give me an example? And he talked about arrhythmias, and I think he was talking about a particular kind of effect on the conduction of the heart that is called prolonged QT syndrome. But so there's both direct and indirect effect on the heart, according to what I've just recently heard. And it sure wouldn't hurt to have an expert checking on you every year or 6 months, especially if abiraterone. Oh no, that's not going to be one of your drugs, is it? But yeah, I think it would be a good idea too.
Okay, thanks. Right now, I'm just going to be on Eligard.
No, but still, Eligard itself is a cardiac risk.
Yeah. Okay.
According to these guys. Yeah.
All right. That's all I had.
Okay. Thank you, Tom. Now, I'm just curious, when they're going to do spot radiation for your bone mets, they're going to radiate your prostate, but what about the whole pelvic region? Are they going to do that too?
Well, I haven't seen the oncologist yet, the radiation oncologist, but that's what we discussed yesterday. He talked about, well, I don't know. Talked about radiation, just radiating the prostate versus the entire area. Is that what you're saying?
Yes. I mean, being that you have bone mets, usually the way the cancer spreads is through the lymphatic system and then into the blood and then into the bone. So, okay. Yeah. Anyway, just talk to them about it. See what they say.
All right. All right. Thanks, Lynn.
So,
well, I mean, it sounds like what it might be is defined as oligometastatic disease.
Correct. That's right.
And there are trials which say that radiating the Mets along with hormone therapy might give a long-term, very long-term remission.
Yeah, we looked into that. There was at Ohio State, there was or still is, a trial about that. But I wasn't approved to go into that.
Because of the lung.
Because of my lungs at the time. So.
But the doctor seems to think that we can just go ahead and do it.
Yeah.
Okay.
Okay, thanks.
Carl Foreman, you're up.
Okay. I read something within the past few days, I guess so many emails, about a lutetium-177 trial. And one of the exclusions on that specific trial, I don't remember where the location was that if you have visceral metastases, that's a exclusion. And I'm just wondering that if, for myself, I have been diagnosed with some spots on my lungs, which of course that is technically, I think, a visceral metastasis. So I wouldn't qualify for that trial. And I'm not sure whether that's a common factor for lutetium-177. I know, Herb, you're about to start the trial. Dennis, you've been in having this therapy. And it was a bit disconcerting for me that I may not be eligible in the future to make use of lutetium-177.
I wouldn't worry, Carl. And the reason I wouldn't worry is because you're not going to go into a lutetium-177 trial. Once you get through your rounds of chemo, and if you need lutetium-177, it'll be approved. Right?
Okay.
By the time you need it. So
okay. Well, there goes that
that's
answer.
why I wouldn't think you would worry about it.
All right, I appreciate that. The other comment I did want to make, and I know that Roy is not on the call any longer, the 93-year-old gentleman whose son was helping him with his hearing issues. And I just kept thinking throughout this entire meeting, someone who's at that age, and look, you can't fault anyone for continuing to fight as much as they can, but considering what options he has at that age, would it not make more sense to not go through some of these treatments that can cause, more harm than good, especially at that age? And, he is exercising. He didn't say anything about, or I didn't hear anything about a diet, but I would expect that maybe the best thing for him at that age would be, simply diet and exercise instead of pursuing some treatment, which, how much longer, quite honestly, how much longer does he have? God bless him that he's 94 years old. He's got some kidney issues that he explains, but I just didn't see that there was really a viable option for him at that age.
Well, I think one thing, Carl, that I think would be involved in any decision is that bone mets, if they're left unchecked, can be really, really lead to major pain issues. And so I don't think it would be necessarily done only for prolongation of life. I think in this case, if if he could tolerate Xofigo, which would knock down his bone mets, it may, allow him to have a much higher quality of life.
Yeah, I agree with that. And is anyone else shocked besides me that he had 50 bone mets and he said, I don't have any pain?
I mean,
that's amazing.
They must be really small because his PSA isn't all that high. Right. And so, I mean, I agree with you, Carl. That's why we sent him to a GU oncologist. Lenny will not, and these guys, all of them, and the people I've spoken to, all take age and, status into account before they provide any therapy. So if they thought he couldn't tolerate it, they're not going to give it to him.
Right.
You know, Carl, many of us, at least I do, and you know, in my 60s and 70s, I'm always working with the balance of quality and quantity. I'm not going to wait till 94. I mean, I'm always thinking about that. You know, what's the right thing to do at this point in my life, no matter what it is. And, it's a challenge wherever one is, for sure.
Right. Yeah, and also considering the fact that he doesn't have much of any pain, his PSA is not a tremendously high number. It just seemed to me that, you know, live your life, and God bless you that you've reached this age.
I mean, it's true. I felt that it's just great that if I don't think I'm going to see 94. You know, it's
Right.
beyond my even beyond my thought pattern. But when you're there, you think like us, right? If we were 94 and in the same situation we are now, we would think like we are now. Well, I got to keep going.
But that's a good point. Maybe he shouldn't undergo any therapy until he becomes symptomatic. If he has no symptoms,
Right.
you know, enjoy life.
No, it's not how my aunt thinks, who's 95 right now, with multiple issues, this and that. She says, you know, I've lived a life and I don't want to go through any real pain and suffering, and I'm going along. And if I die tomorrow, I die tomorrow. If it's in a year or two, it's in a year or two. I really don't want to be 100 because I live with people I see that are 100, all are miserable, basically. And I want to just enjoy my days and not do any unnecessary stuff, except if something really seems like it might have a direct, immediate benefit.
Okay, Carl, did you have anything else? Oh, by the
No,
way.
that was it. That was it. Thank you.
Okay. I was speaking with Ken Anderson today, and he's waiting to get into a lutetium, I guess, compassionate use trial or whatever they're calling it, managed access.
Managed access.
And, yeah, he claims Paul Korn told him that approval of lutetium is more likely to come in June rather than April.
Well, I did have a conversation last week with two my two GO oncologists. I did have a conversation with my NIH person on Tuesday and Carducci at Hopkins on Thursday. And with Carducci, I had a very long conversation about lutetium. And he felt that the reason for this managed access trial is they really still are collecting data that they're feeding to the FDA. And that's why the FDA has not approved it. I said to Mike that I thought, you know, maybe the FDA would just, you know, they need to convene a committee. And his response was that the data are now so strong that they would not need a committee to approve this. They're just staff. But the implication I got is that this managed access trial is actually to collect data. And Nancy says that, of course, it's to collect data. They're going to pick the people to let into the managed access trial who will benefit a lot so they can show more benefit. So there's all kinds of potential, you know, either nefarious or needed interpretations of why no approval and why they're doing the managed access trial. I mean, okay. I was told that I was chosen because they are looking at their list at Hopkins and picking the people who they thought would benefit most.
Yeah. Yeah, I'm sure they should be triaging it, something like that. You know, that's why I mentioned that it's unlikely that that 94-year-old gentleman's going to be put at the top of the list. But
Right. No,
who
I
knows?
don't think he'll get lutetium. And they may not even want to give him Xofigo.
Yeah.
And I think I think a good GU medical oncologist will take all of those things into account. They're not going to simply say, oh, you want it, we're going to pump it in.
All right, guys, we're getting near the end point, so I want to go to Larry Fish, Brooklyn's own.
That's me. The joint, Brooklyn is the joint. So, I mean, briefly, going towards my 6th year, did a brief chemo and then Lupron. Never went to second-line androgen yet. I'm at that point now. My PSA has really been wavering up and down for many years, but now clearly it's gone 0.6, 0.7, 0.9. And we're at that point where we have to make some decision about what's next. I have diabetes, so one of my concerns is like if the second androgen will put a strain on diabetes. And I'm looking at a version of something like Len did, which is thinking about switching, if possible, to add darolutamide. And then if that brings things down to a very low level again, to use it as a monotherapy. Although it's not a protocol that my oncologist approves of, she's just aware that that's the way I'm looking at it. I have scheduled tomorrow my usual bone scan, my CT, thorax, abdomen scans, and we're hoping it's not going to show any Mets, which is going to make me eligible for a Pylarify scan. And I want to get that Pylarify before I make any decisions, because I'm looking at either basically going to darolutamide directly, or perhaps if there's something specific, maybe thinking about a whack-a-mole before that, and see what that does. That's where I'm at. This is my plan, and it is to basically switch to darolutamide if I'm able, and then if that's successful, cut back, take a Lupron holiday, and just refuse to take Lupron shots. See where that leads me, and try to play with that balance. Anyway, that's the plan I have.
Yeah.
The way it's on for these last 5-6 years, it seems like if things go okay, I should get a couple more years out of whichever second line androgen I choose, unless something unusual is developed. I don't know. That's just where I'm at, and wondered if anybody had any opinions or ideas.
Yeah, Larry, I would say the best strategy, if you want darolutamide, is first get it before you do the PSMA scan. You know, like do the Brett?
Definitely, that's our plan. Do these basic.
Okay. I thought.
No, to get the basic scans, and hopefully they don't show any, Mets, which will make me eligible. And at that moment, switch and then do Pylarify over the next month, and use that to determine the idea of perhaps trying a whack-a-mole.
Okay, sounds good to me. Anybody else want to comment?
It sounds great if it works, Larry.
Yeah.
I mean,
if it turns out there are Mets and they're multiple, then I would just go to a second line. Probably Abby.
No, but darolutamide would be fine.
Yeah, that's what I'm looking to, where I'm trying to head. And then I'm hoping that's going to be effective, and then deal with the diabetic results and maybe cut Lupron to help everything out, and see how long that goes. That's the road I'm on. Not really there at the lutetium stage or something more aggressive, not yet.
Larry, since I went on monotherapy, darolutamide, my energy has really increased tremendously. I mean, last week I just changed my solar hot water heater by myself. A couple weeks before that, I redid the clutch on my 24-year-old Toyota truck.
Yeah, life.
Yeah,
You know, I've been enjoying life, and going to continue.
I was dragging my butt around when I was on Lupron with it.
Sure, you have that brain fog. It's cumulative.
When Lupron stopped working for me, my oncologist put me on Casodex, and I was on it for about a year, and my PSA just went down and then slowly rose, very slowly. I don't know if that's an option for you, but it might be less damage to your diabetes.
I think I went through that 4 or 5 years ago when my PSA had gone up like pretty quickly to 0.6, and Acidex dropped back down to 0.1 something, and that's where it's been fluctuating back and forth, up and down over the years, but now it's sort of starting to trend pretty clearly upward and reach that point where sophisticated scans should show something. So I'm looking forward to switching to darolutamide and hopefully cutting out Lupron for a while, seeing how that goes. With just taking a look at the idea of whack-a-mole if there's something really specific. That's just what I wanted to share and see if anybody thought I should look at this differently.
Yep. Yeah, it's a great plan.
Okay, I'm going with it.
When is the CT scan planned?
Tomorrow.
I wonder if, in order to get you the darolutamide, they may want you to do a traditional bone scan.
I will do that. Tomorrow. I'm doing a full body bone scan. Do both, and that's what I've been doing every 6 months or a year.
Okay.
Want to do that first, and hopefully get that, and as a result of that, with being castrate resistant, being able to go directly to darolutamide. A number of other things. I mean, we had this discussion about cancer burden, and my doctor says, definitely your cancer burden compared to when PSA was 200, 300 in the beginning is much less, and the Lupron has been effective, and your cancer burden is less. It's also a time to think about adding Provenge along in this pathway. But that's a separate issue and not the thing I'm discussing at the moment. I've been pretty conservative in the way I approach things, and it's been going pretty well for me.
All right. Herb, I've heard through the grapevine that you're going to transition into...
I'll just leave it. I'll leave it open until someone shows up.
Oh, okay. So then we've got until someone shows up from the next group.
Right.
Anyone like to comment on it?
In the time?
Susan just showed up.
Oh, okay. Well, there we go. Viva Ukraine.
Stop recording.
Yeah, I will.